Yeah, we are live now.
So we are live.
Okay. Puja, please start.
Okay. All right. So good afternoon, everyone. On behalf of the organizing committee of the masterclass and SRCC Children's Hospital, I would like to welcome everybody today afternoon. So this week's masterclass we have a very interesting lineup. It is a topic that is very relevant to general pediatric practice. We have three topics lined up. To start with, I would like to just give a brief introduction about SRCC Children's Hospital. So we are an exclusive pediatric tertiary care referral hospital based at Haji Ali. And just to let everybody know, we are functioning OPDs, we are functioning operating theater, and we are admitting patients in our ward service. To start with, I would like to introduce our first speaker for today, Dr. Zeenat Sadikot. So welcome ma'am. So ma'am has about more than 30 years of experience practicing ENT in South Mumbai. And she will be talking on current thoughts on tonsils and adenoids. Welcome ma'am.
Thank you.
Ma'am, you may share your screen.
Yeah.
Can you see?
Can you see us? Can you see
Yes.
me now?
Yes.
Yeah. And the slides too, is that fine?
Yeah, ma'am, you can just switch to slideshow.
All right, now can you see? Is that good?
Yes.
All right. Thank you, Dr. Puja. Good afternoon, everybody, and welcome to the masterclass organized by Narayana Health and SRCC today. My topic is going to be adenotonsillar disease, the current status and thinking. So, adenotonsillar disease and tonsillectomy is mentioned very early in medical history and literature, but it is only in 1908 which marked the arrival of ligatures and catgut sutures to control perioperative bleeding, that tonsillectomy was really aggressively pushed as a universal solution and treatment for all infections of the throat, nose, ears. It was also used, it was also performed for diseases far away from the tonsils. In fact, so much so that by the 1960s, it was even being advocated for children suffering from growth and behavioral problems, and it is also mentioned in the treatment of mental illness. So, obviously, the backlash to the indiscriminate removal of the adenoids and the tonsils was inevitable. Today, we hope to give you an update on our current thinking and approach to a patient with adenotonsillar disease, the clinical diagnosis, the appropriate investigations, medications with judicious use of antibiotics, newer surgical procedures, newer instruments have all evolved to make the scenario today very precise. So what do we do? The tonsils and adenoids are made up of lymphoid tissue, part of Valde's ring, which is arranged around the opening of the respiratory and the GI tract. They are primarily protective in function. The macrophages, the B lymphocytes, the T lymphocytes, and the antibodies which are present are the first line of defense against bacteria and antigens which enter through the nose and the mouth. If, however, the tonsils have been overwhelmed by infection or they are removed because of hypertrophy, there is no evidence of immunocompromise. The body can still fight infections because the rest of the immune system is intact to continue the fight. So basically, symptoms of disease, tonsils, and adenoids, the symptoms are either infective and or obstructive. So you will have a patient who complains of fever, sore throat, enlarged glands in the neck. A blocked nose and ear complaints may be due to both infection as well as obstruction. The decreased hearing is a byproduct of the ear complaints. And then we have a separate category of what we call the sleep disturbed breathing, which is purely obstructive. If there is an infection, it may be viral, bacterial, or mixed. Common viruses which affect the tonsils and adenoids are the influenza, parainfluenza, and the respiratory viruses. The most common bacteria is the beta hemolytic streptococcus, and often the Haemophilus influenza, streptococcal pyogenes, the M. cataralis, as well as Staph aureus is frequently found in infections of the tonsils and the adenoids. To differentiate between a viral etiology and the bacteria, clinical examinations do give us a little bit of a clue. A viral adenotonsillar pharyngitis will be associated with maybe red eyes, few conjunctival symptoms, watery rhinorrhea, skin rashes, petechial hemorrhages in the oral cavity, even distant symptoms such as diarrhea. But rarely is it accompanied by painful swollen cervical lymphadenopathy and or an exudate on the tonsils, which symptoms are basically hallmarks of a bacterial infection. The exception being, of course, infectious mononucleosis, which is a viral disorder, but accompanied by cervical lymphadenopathy. If we come to the last symptom, that is the sleep disturbed breathing. As I mentioned, this is due to an upper airway obstruction. The terminology covers a broad spectrum of degree of obstruction. Snoring is simple snoring, just a rhythmic sound, may be accompanied by extra movement. The child maybe have a little wake up in the morning, not completely rested. At the other extreme of the spectrum, is what we now known as obstructive sleep apnea. Obstructive sleep apnea, there is persistent snoring, there is significant obstruction of the upper airway. There are apneic spells that is cessation of breathing. The patient stops breathing. Adults, it is significant if each episode is more than 10 seconds or more. In children, anything more than 6 seconds we consider significant. Each of these apneic spells is accompanied or interspersed with a choking, gagging sensation, whereby the patient is aroused from sleep. It leads to constant waking up during the night. Patient is not rested in the morning. In an adult, it will manifest as extra somnolence, sleepiness during the entire day. But in a child, the child will be hyperactive, irritable, complain of headaches, behavioral problems. Yes, definitely. In between is the upper airway resistance syndrome. The apneic spells are not so severe. The obstruction may be partial. The severity, basically, of the obstruction is maybe requires investigation a lot more thorough than that which is available just by the history. This is a classic photograph of a child who suffers from adenoid hypertrophy. It's called an adenoid facies. There are small nostrils, short upper lip, crowded mouth, there is a high arched palate, this child will be suffering from an obstructive sleep apnea. You walk into your clinic with a mouth open, all your antennae should go up at this point. Sorry, before we come to any kind of indications for surgery, I have to say that the diagnosis of adenotonsillar disease in most cases is clinical. However, patients with ear complaints should be advised audiology, both pure tone and impedance to determine a hearing loss and whether there is fluid present in the ear. This examination may be done after the course of medication, but it is good practice to get it done anyway to ensure that the hearing has recovered and is good, and that there is no remaining fluid in the ear, and also to prevent any kind of long-term sequelae. Minimal investigations are necessary in adenotonsillar disease when you're first examining a patient. But yes, the audiology is necessary. If there are obstructive symptoms, then you would consider a lateral view of the nasopharynx. If there is chronic rhinosinusitis associated with the adenotonsillar disease, you will think in terms of radiological evaluation of the paranasal sinuses. For the obstructive symptoms, besides the X-ray of the nasopharynx, the gold standard would be a little endoscopic examination of the nose, which visually you can examine and confirm the level and degree of obstruction in the nasopharynx, most often due to the adenoid hypertrophy. This is especially important in children who are obese, who have maybe a mild craniofacial abnormalities, and in those patients who come to you with symptoms of obstruction, but on examination you see relatively small tonsils, which clinically you cannot correlate with the large adenoids, which the history is suggestive of. Further, in investigations of sleep disturbed breathing, I would think that the next step would maybe be pulse oximetry, which is a screening procedure, a mini sleep study, which is basically just pulse oximetry and a microphone and video watch over the child while the child is asleep. A full sleep study is usually reserved for adults. We don't do it in children, but it could be possible in an older child. Treatment too of the acute attack of adenotonsillar and adenotonsillitis may be just supportive if a viral etiology is suspected, involves analgesia and antipyretics. Paracetamol is good enough. You ensure good hydration, rest, diet. Anti-allergy medication, mucolytic agents, decongestive nasal sprays in the presence of hypertrophy and obstruction of the upper airway. Antibiotics, of course. If a bacterial etiology is suspected, if it is a repeat or a severe attack, if you have been treating the patient with antipyretics and the viral attack has not subsided, the patient's general condition has not improved in 48 to 72 hours, yes, antibiotics do have a place in the treatment of adenotonsillitis. The dosage should be initially conventional. Medication has to be regular, taken at least for 7 to 8 days, and taken along with all the supportive measures. My drug of choice today would still be amoxicillin clavicolic acid. In case of any allergies to the medication, I would then opt for something like clarithromycin, clindamycin, any of the macrolides, clindamycin, maybe even the cephalosporins. in a severe infection, which may have spread a little locally, as in a case of peritonsillitis, I may add an antibiotic which is effective against anaerobic infection as well. Of course, if there are repeat infections, the patient comes twice and thrice, then antibiotics after a culture sensitivity of a throat swab taken directly from the exudates on the tonsils would be indicated. Even with the best of medical intentions, attention, and medication, there are many patients who are not relieved of their symptoms. Their quality of life is affected, and there is a fear of clinical deterioration. It is to these patients we have to offer a thoughtful surgical intervention. So we come to indications of surgery. Adenoidectomy, tonsillectomy may be done on its own in obstructive symptoms of the adenoid. I would think that there is some indication for just adenoids being done, but usually they would be performed together. The obstructive symptoms of sleep-disturbed breathing, recurrent rhinosinusitis. Secretory otitis media is both obstructive as well as there is an infective element. So removing the adenoids gets rid of the obstruction to the eustachian tube, permits drainage and aeration of the middle ear. The adenoids are also often implicated in the formation of a biofilm, which is an infective etiology for the chronic secretory otitis media. Even in an infected chronic benign otitis media, adenoidectomy, tonsillectomy is indicated if there are repeated attacks to protect the ear. Mouth breathing, speech abnormalities, dental occlusion, malocclusion may all benefit with the removal of the adenoids. So we come to tonsillectomies. I think that is where there is the greatest thought being given to indications. And after a lot of studies, two very big studies done both in the US and in the UK, I think the indications which we now follow are that if there is recurrent acute or acute on chronic tonsillitis, more than 6 a year, 6 to 7 in one calendar year, or maybe 5 or more attacks in the past 2 years, 3 or more attacks in the past 3 years. Basically, it is if there is more than 2 weeks of time lost from school and or work, we should think in terms of
Ma'am, we can't hear you. I think your screen is frozen.
Yeah, I think they have a problem with the net. What we can do is Vishal can take over. Vishal?
Yes, sir.
Yeah,
Well,
you can speak something about tonsillitis, and if we get back Dr. Zeenat, Sadikot, and Shruti, otherwise we can start your talk and then come back to their talk.
sure, we could do that way.
Yeah.
Mahesh, can you just turn on the screen sharing, please?
So while we're doing that, I'll just like to make a few introductions. Okay,
I'm
so
sorry.
Yeah. So Puja, you can. Dr. Zeenat is back. So I
I'm
think
okay.
so
let's go
sorry.
ahead. Yeah.
I
Vishal,
had a tech.
Vishal, you can stop sharing and let Dr. Zeenat come
Good.
back.
Done. Done.
Okay.
Yeah, yeah.
Sorry, Dr. Vishal, I'm nearly done in any case. Is that okay? Is my slides visible?
No, ma'am, you'll have to share your screen again.
Yeah, here, translate communication. Yeah, I apologize. I'm so sorry for this. And I would think the most important is the positive culture of the group A beta hemolytic streptococci. If that has been picked up on repeated attacks, I would think in terms of tonsillectomy. Next one, we got it. Anyway, the other indications for tonsillectomy would be if there is a tonsillitis, acute tonsillitis accompanied by febrile seizures, peritonsillitis or peritonsillar abscesses, more than 2 episodes is, I think, where we will recommend tonsillectomy. And of course, the tonsillar hypertrophy, if it is accompanied by the adenoids. Tonsillar hypertrophy causing airway obstruction, obstructive sleep apnea, any kind of sleep disturbances. Difficulty in swallowing or any interference in speech, and especially any suspicion of malignancy. If there's a unilateral hypertrophy and or ulceration on the tonsil, that is an indication to get rid of the tonsils and biopsy. These are relative indications, carriers of the group A beta hemolytic streptococci. We don't see much of diphtheria at all these days, but a chronic tonsillitis with a foul taste and halitosis. The patient is constantly complaining of discomfort in his oral cavity, usually accompanied by tonsillar lids or follicular exudates, dry follicular exudates on the tonsils, which are unresponsive to medication. A tonsillectomy makes a great change in the patient's life. And of course, there's frequent streptococcal throat infections in patients with related heart and kidney disease. Contraindications, because tonsillectomy is rarely an emergency procedure. The relative contraindications are hematological, with either anemia and coagulation disorders. There is always time to address these disorders before surgery is done, as well as if in the presence of active infection. I would hold on for an interval period. Where you have to really seriously think about tonsillectomy is in a patient with a cleft palate, either overt or with the submucous palate, the cleft palate. That comes into play in a child with a Down syndrome, because the Down syndrome children usually have a cleft palate. They have large adenoids. They are mouth breathers. They show signs of obstructive sleep apnea. So making a decision to do an adenoidectomy with tonsillectomy in a child with Down syndrome is should be a little circumspect. Thank you. I'm sorry for the glitch, the technical glitch before. I will give the over the slide show to Dr. Shruti, who is going to be talking on the surgical aspects of tonsil and adenoid removal. Thank you. Shruti.
Okay, thank you very much, ma'am. That was an extremely informative lecture. While we move on to our second speaker, I'll just take a few minutes to make some introductions. I'd like to welcome our two chief coordinators for the masterclass, Dr. Shah, who is our senior pediatric surgeon and our expert in pediatric laparoscopy, and Sonu Udani, madam, who is our senior intensivist and medical director. This masterclass is being moderated by two of us. I'm Puja Mehta. I'm a full-time neurologist at SRCC, and Dr. Avisha, my colleague, he's a full-time orthopedic surgeon. Please feel free to put in your questions in the YouTube chat, and we'll take in all your questions and do the question answer session at the end of all the lectures. So our next speaker is Dr. Shruti Bansal. She is a full-time ENT surgeon at SRCC Children's Hospital. She's going to be talking about her experience of coblation and micro debrider aided tonsil and adenoid surgery here at SRCC.
Hi, Puja, can you see my screen?
We can see one screen, but there is big black something on top of that. Just
Am I audible?
You are audible.
Can you see, Puja, my screen now?
It's just a black rectangle.
Yeah.
Need to unshare first.
Hi.
Do it again.
Puja, can you hear me?
I can hear you, yes. But I can't see your screen.
Shall I start?
No, you need to unshare and reshare. Stop sharing first and then reshare. We can see only Dr. Zeenat Sadikot's screen.
Stop sharing the screen.
Yeah. Now,
now you can see.
We still.
Now you can see.
Yeah, you're still opening up your presentation.
I have already opened up and I'm sharing the screen. Can you see it?
No, you'll have to choose the window that you've opened up. Yes.
Can you see
Yeah,
that now?
got it. Yes. Perfect.
Shall I start?
Yes, do go ahead.
Not able to hear it. Dr. Rasik,
Yes.
I'm not able to hear you back.
Yeah, Puja said, start please. Shruti, you are on. We can hear you. We can see you. We can see your slides. Please go ahead.
I'll just come there, I think. And I'll just come there.
Shruti, we can hear you.
Okay, sir.
Yeah, everything is fine. Please go ahead.
So, hi everyone. Good afternoon. I am Dr. Shruti Bansal. I'll be talking on current trends in the adenotonsillar surgery. Before I start for the current trends, let me go to this ahead. So, going back to my residency days, there were times, some 8-9 years back when I was first shown the tonsillectomy.
Shruti, can you
I
hear me?
remember that, only the consultant
I'd like to just interrupt.
what is happening inside the oral cavity, because we as a ENT surgeon work in very, very narrow spaces. So it was very difficult for us as a resident to see what is going on inside the oral cavity.
Shruti, just take a minute. I think you have
Puja,
two
I can't hear you.
computers. You have two computers, so one of them will have to be muted.
Hello?
You're echoing, so the other laptop will have to be muted. You'll have to mute
Just
one
give
of
me
the
a
two.
second, Puja. I'll come to the other laptop. You have already logged out? You are logged in. How do you? This is so pathetic, my God. Okay, share screen. Coblation, PT. Tonsil.
Hello? It's paused. Why?
Yeah, we can hear you.
Yes. So I'll begin again.
We are not able to see your screen, so please open
Are
the.
you able to see my screen now?
Yeah, you'll have to open your presentation. Can't
I
see
have
it.
opened my presentation. Can you see it now?
No.
Close one screen. The top screen, what we are seeing, I think that needs to go.
And then again,
No.
share the screen. This one.
Can you see it now?
Yeah, we
Yes.
can.
Okay.
Slideshow.
Just go to
Slideshow.
slide mode.
Yeah.
Now can you see?
Yes,
Yes.
we can see, hear you. Please go
Okay,
ahead.
so I'll start again. So I'll be talking on the current trends in the adenotonsillar surgery. Before talking about the current trends, I go back to my residency days when as a resident we were being taught about the tonsillectomies and the adenoidectomies. And since in those times the only way to do was the core dissection method, and the consultant who was doing the surgery was the person who was able to see what is happening inside, because we as an ENT surgeon works in these small orifices. So we had learned seeing these techniques, which are still good, still relevant, and still done widely. Coming to tonsillectomies, these can be either a total removal of tonsillar tissue, which is known as the extra tonsillectomy, or removing a part of the tonsillar tissue and shaving it off up to the tonsillar capsule behind the capsule, known as tonsillotomy. This is a relatively newer concept which has come now, and this has been possible with the instruments which are available now. Coming to the methods of tonsillectomy, the methods be a cold method which back again. There are dissection and snare method, which is the most commonly used method by most of the ENT techniques which to the list. Various hot methods are the ones which uses heat energy in the various forms to break the tissue bonds and remove the tonsillar tissue from the fossa, be it cautery, laser, a coblator wand, or a radiofrequency wand, or a harmonic scalpel. So basically what I want to say is that all these techniques or all these instruments are like various tools in the armamentarium of a surgeon. No tool can be labeled as good or bad. It depends upon how you are using it. It is actually the man behind the instrument which is using it. The ultimate aim is to remove the tonsillar tissue or the adenoid tissue and giving the maximum benefit as well as comfort to the patient. So it depends upon the surgeon and also on the patients, and we balance out the pros and cons and see what is the best for the child. It all started with as old as Gilliton's tonsillectomy. It was rather considered a very barbaric method, wherein patient was made to sit in the chair and he would open the mouth and the tonsils would be scraped out of the throat using this Gilliton. It was associated with lots of pain and bleeding and complications. There came a time then when, with the advent of better instruments, the dissection and snare method came. This is how we started learning, and this is a most commonly used method, wherein the complete tonsillar tissue is removed with the capsule away from the tonsillar bed using a forceps and a dissector with the wire loop called a snare. Coming to intracapsular tonsillectomy, which is a relatively newer concept, and this is what we have widely started doing in SRCC. Tonsillectomy is a technique wherein we remove the tonsillar tissue from medial to lateral, going up to the tonsillar capsule, and we leave the tonsillar capsule intact, because of which the obstructive portion of the tonsil is removed. However, since we do not touch the bed of the tonsil, which has all the sensitive structure, the post-op complications, pain, and everything is much better, and recovery is much more rapid. This has been possible because of the instruments like microdebriders and coblators, which can actually eat away the tissue from the medial side of the oral cavity. This is a microdebrider which uses, it's a powered rotatory shaving device. It has an inbuilt suction, and it just cuts away the tissue and just removes the tonsil and obstructive part of the tonsils within the oral cavity. I would like to emphasize that it's a beautiful tool, but at the same time, it can cause a lot of harm if not handled properly because it has a sharp cutting rotatory edges. What we most commonly use and what we have started using in our setup is what is known as a coblator. The coblator uses a field of plasma to ablate the tissues. It basically combines a radio frequency energy and a saline to create a plasma field. The advantage is that it is a relatively colder technique because the heat generated in the area is much less, which is just up to 40 to 80 degree, which is much lower than using a bipolar or a unipolar cautery or even a laser where the temperatures go as high as 400 degrees Celsius. The advantages are that the bleeding is much less because it has an inbuilt coagulation system. The post-operative pain is much less, the healing is faster, and patient starts eating much faster and delayed complications are much less. This is how a coblator wand looks. It's a beautiful device where it is a 4-in-1 tool which ablates the tissue, helps us in the hemostasis. It has an inbuilt suction and inbuilt irrigation system. So the lateral damage, the collateral damage in this is much less. And at the same time, it eats away the tissues and gives us the complete bloodless feed. The advantage of a coblator over a microdebrider, I would say, is that this can be used to do both tonsillectomies as well as tonsillotomies, unlike microdebrider, which is mainly used or can be used to do a tonsillotomy or remove only the obstructive portion of the tissue. Similarly, coming to the adenoidectomy procedures, the first curettage adenoidectomy was defined in 1885. The beauty is that it is still very commonly used by a lot of ENT surgeons. This is on the left hand side, the image you see is an adenoid curette. The curette is used to just scrape out the adenoid tissue from the back of the throat. So the disadvantages with this procedure is that it is a relatively blind procedure. There is no way you can see with the naked eyes at the back of your throat. It obviously leads to bleeding because it leads to scraping of the tissue and causes injury to the structures which are, essential and which we don't aim at. The removal is usually inadequate, especially in the areas like intranasal portion, or which is the most important obstructing portion, or the area around the eustachian tube. It leads to eustachian tube injury, sometimes edema, and later on pain and problems in the ear. And sometimes it also leads to nasopharyngeal stenosis. With the evolvement of the endoscopes, there has been a drastic change in the way we have started doing the adenoidectomies. Be it the adenoidectomy is done using the endoscope and the adenoid curette, or using a microdebrider, or what we use in SRCC here is a coblation adenoidectomy. The advantages what we get with the coblation adenoidectomy is that A, because we are using an endoscope, we get a better visualization. B, we get a magnified view. C, there is a less of collateral damage because of the inbuilt features of the coblator. D, there is an easy accessibility to difficult areas like posterior choana or the peritubal areas. And these are, trust me, the most important areas which are responsible for giving the obstructive symptoms to the patient. The hemostasis is assured, the healing is much rapid, and the pain is much less. So this is a video of one of our patient wherein I think this video is not going to play from here, so I'm just going to play it separately for you guys. So in this video, we took the endoscope has been put from the endoscope has been put from the nose, and you can actually see the intranasal portion of the adenoids which were obstructing the posterior choana. This is a coblator which we have put from the oral cavity.
Shruti is not able to visualize the video.
You're not able to visualize the video. Just
No.
give me a second. Just give me a second. I'll try it. Just give me a second. Where is the video gone? Can you see it, the video part now? Can you see?
Yes, can see it now.
Okay,
Thank
so
you.
this is the endoscope has been put through the nose, and the coblator wand is going through the oral cavity. This is the intranasal portion of the adenoids which we are removing. So this wand just shaves off the adenoid tissue from the posterior pharyngeal wall, and it makes it gives a very good bird eye view to us, and we are able to remove all the tonsillar tissue, all the adenoid tissue. It has an inbuilt hemostasis thing. Now I've put the camera or the endoscope through the oral cavity to show how beautifully the posterior choana are seen and are unobstructed now. So that would be all from our side. If anybody has any questions, I think we'll take it in the end. I'll now pass on the screen to Dr. Vishal.
Okay, thanks, Dr. Shruti.
Yes.
That was really good. For me, the last time I think I did ENT and instruments was in MBBS. So this was a really good refresher and a lot of new things. We'll move on to our next speaker, Dr. Vishal Baldwa. We'll be taking all the questions in the end. So please feel free to type in your questions. So next speaker is our dynamic intensivist and pediatrician, Dr. Vishal Baldwa. He is an intensivist at SRCC Children's Hospital, and he has his private practice in Goregaon. He will be talking about tonsillitis and adenoiditis from a pediatrician's perspective.
Am I audible and visible to everyone?
Yes. Can't see your screen yet.
Mahesh, can you start the slides, please? Mahesh?
So the screen is shared.
Screen is shared?
Yes.
Just a second. So at the outset, would just want to thank the organizing team for masterclass, Dr. Rasik Shah sir and Madam Udani for organizing this. It is also a welcome break to be talking about something other than COVID. So hopefully I can just give you a pediatrician's perspective of how we deal with tonsils in the clinic and what are the things we really look out for. Next slide, please.
Sorry, I don't think we can see your screen yet.
Is Mahesh there?
Mr. Mahesh?
Vishal, where is your PowerPoint? It's on your laptop or?
It's with Mahesh.
Arnab, do you have that?
The screen is shared. We're on the first slide.
Yeah, but we can't see that. You need to redo it. Undo it and redo it.
Can you unshare and share?
First, if stop sharing and then reshare. What we can see is just a black screen with saying that Vishal Baldwa has started screen sharing.
So now is it visible?
No, no.
Sharing chalu hai.
I think Dr. Vishal, you have to stop sharing your screen and let Mahesh share his screen.
Yeah, we can see now.
Now you can see that?
Yeah, yeah.
All right. Can you come back to the first slide, please? So now we all know that this is a very common presentation in the OPD. The most frequent age group we look at is between 4 and 12 years of age. And the symptomatology, as Madam Zeenat has already pointed out, is pain while swallowing, presence of fever, change in the voice. This is a very common symptomatology, right? Next slide, please. Next. So what do we actually look out for once we are in the OPD? Our main idea is to make out whether this is an acute episode or this is acute on chronic. What obviously helps here is a history. If there are multiple episodes, this is a chronic tonsillitis we are looking at. And also what helps is the appearance of the tonsils. If the tonsils are red and inflamed, very angry looking, you're looking at acute on chronic. Or else the tonsils are simply enlarged in size, but they are not really very inflamed, not filled with exudate, is more likely to be chronic tonsillitis.
Now he has written.
Next slide, please. Also, you make a note whether the child is sick looking, is the neck swollen, or if there is any trismus. Trismus is the inability to open the mandible comfortably. All right. Now, these would be signs of complications, especially peritonsillar abscess. So we just want to make sure. Can we mute the other participants?
Please mute everyone else except Dr. Vishal and Puja. Yeah, please go ahead.
So now how do we know if it is bacterial? Next. So once you look at the throat, you look at a lot of exudates here covering both the tonsillar crypts. You look at the uvula, which is right there in the center. It has become pale and edematous. And of course, the child from the outside is a little sick looking and uncomfortable. So this all goes in favor of it being a bacterial tonsillopharyngitis. When you look at the viral picture, most of the viral pharyngitis, viral tonsillopharyngitis, they are conspicuous by the absence of exudates and with the uvula looking pretty much normal. Okay, next please. Now I am about to highlight a few cases, and the entire idea being tonsillitis I'm sure everyone has seen and managed, but there are a very few close tonsillitis mimics that we need to be aware of to make sure that we don't miss other cases in the interim. So first case, this is an 8-year-old child. Next. Comes with history of throat discomfort, headache, malaise, and stomach ache. Now, of course, this is the corona season. You have to be very cautious if you're attempting to look into the throat of such kids. But this is the picture that we look at, and we see that there is a good amount of exudate covering the tonsils. The uvula is swollen. But the only thing which does not really fit in are the systemic complaints. There is malaise, there is stomach ache, which would not be expected in acute tonsillitis. It is a fairly localized disease otherwise. Next, please. Once you get the presence of systemic signs, you always make a complete examination. So when per abdominal examination may be done in a case like this, you may find the spleen to be positive. If spleen positive with tonsillar enlargement with exudates covering the tonsils could very well be infectious mononucleosis. The causative agent being Epstein-Barr virus. And here what you could do is just send off a CBC with peripheral smear reporting. They will report atypical lymphocytes. Next. And the definite test is the presence of IgM BCA antibodies. That will be the hallmark for EBV. Another very peculiar characteristic of EBV is if you do think of this as bacterial tonsillitis, if you don't look out for the spleen and you give a molecule like amoxicillin, EBV along with amoxicillin gives rise to a very typical rash, and the parents will be more upset about the rash rather than the tonsillitis per se, right? Now this is case number 2. Next, please. This is a 7-year-old girl. Next. Who comes in with neck swelling. You examine her neck is absolutely swollen. You cannot delineate the margin of the lower margin of the mandible. Next. And of course, she's sick looking. You try to do a throat evaluation. You do it with great difficulty. She's able to open the mouth. You put in a speculum. And now you see again that there is a good amount of exudate covering the tonsils. But as compared to the previous slides, where we saw bacterial tonsillitis, we saw a little bit of EBV tonsillitis also. This one is unilateral. It's very continuous, and it's extending not just over the tonsils. It extends onto the uvula, onto the soft palate. Now, if you were to attempt to remove this with your clinic instruments, with your small spatula, you would realize that this is highly adherent. It just refuses to remove, and if it does, it will be with a good amount of bleeding. Next, seeing this picture, you do realize that this is a different appearance, and you ask for history, and you get the history that the child has been immunized, but a lot of the booster doses have been missing. and therefore you come to a retrospective diagnosis of it, this being probably diphtheria. You send across the swab looking for Corynebacterium diphtheria. This child would ideally require hospitalization, IV antibiotics, given the level of toxicity, maybe antitoxins also. And if she were to come with a much worse airway, tracheostomy on a priority, on an emergent basis, may be required as well, right? Next, please. Now, this is the third case. This is a 5-year-old child. Next. Comes in with history of fever. And he has received multiple rounds of antibiotics over the last 2 to 3 weeks, because everywhere he goes, the GP or the pediatrician has looked down the throat. They see the tonsils are enlarged. They think this is tonsillitis. But what is clearly missing, if you look at the picture, is the exudates are absolutely missing. The tonsils are red, but they are not very angry looking. They are not very inflamed. They are not very erythematous. So that should ring a bell that the fever is still going on, but the tonsils are not that uh, problematic looking. Next. So there are no exudates or membrane. Here again, as in the previous child, as in case 1, we would want to do a systemic examination. Here the per abdominal examination reveals the presence of splenomegaly. Next. This child's CBC also shows atypical lymphocytes. The first case was EBV. This one ultimately was diagnosed to be leukemia. So once in a while, cases of leukemia may present with nothing but fever and some tonsillar enlargement, and you will find that they are not responding to your repetitive rounds of antibiotics. They do not have your typical picture of tonsillitis. Next, and they recover. The tonsillar enlargement recovers only 2 to 3 weeks once you have started the right round of chemotherapy. Next. So the diagnostic test that you use for diagnosing your tonsillitis in general OPD practice. Now, these 3 were of course exceptional cases to prime our mind about the possibilities of alternative diagnosis. But for tonsillitis per se, the diagnosis tests are pretty limited. You have a swab rapid test which checks it by the antigen method. Now, unfortunately, this kit is not available freely in our country, but it's a standard of care abroad to do the rapid test. You get the patient to sit outside for a while. The test results come back immediately, and you're able to decide whether the child needs antibiotics or no antibiotics. But as Zeenat madam said, and I have repeated again, if you have tender lymphadenopathy, if you got exudate on the tonsils, we would want to treat them as bacterial tonsillitis. Microscopy and culture usually not the norm, but if somebody is having it repeatedly, or if there's diphtheria as a possibility in mind, you would want to do that. CBC with peripheral smear blood tests usually are not required in tonsillitis, but if you are having systemic signs with prolonged illness and you have found that multiple rounds of antibiotics have not really helped you, then this is something you need to look at. X-ray lateral neck may be required if patient has been presenting with recurrent bouts of tonsillopharyngitis with or without stridor, with or without signs of apnea, then X-ray lateral neck would be required. Next slide, please. Here you would want to look at the tonsils now. The tonsils, the adenoids and the tonsils are pretty much on the opposite side when you take this particular lateral view of the X-ray neck. And what you need to note is that I may not be able to use my pointer, but right behind the soft palate is the adenoids. And the thickness of this nasopharyngeal airway, the air strip between the adenoids and the soft palate, should be almost as much as the soft palate itself. If it is less than half, as in the second picture, then you would realize that this is significant tonsilloadenoid hypertrophy, which is constricting the nasopharyngeal airway. And this is the child who would need reference to a ENT surgeon to consider surgical options to relieve the obstruction. Next, please. Treatment wise for tonsillitis, you usually, if the patient is symptomatic, you just give medications, symptomatic medications for pain and fever. Lozenges may help and are approved. If you're looking at bacterial tonsillitis, antibiotic choices are pretty straightforward. Amoxicillin would still be the drug of choice, 50 milligrams per kg per day for 10 days. Now, they say that 1 day of amoxicillin coverage for this sensitive group A hemolytic streptococcus may just drive down the bacterial population by as much as 90% in 1 day. So the patient may look remarkably well the next day, and therefore parents have a tendency to cut off the duration of treatment. We have to insist that it has to be taken for 10 days. Sometimes easier said than done, but the more the better. If at all a short course is being planned, azithromycin is a reasonable alternative. But azithromycin we would usually want to give only if amoxicillin is clearly not working. or the patient is allergic to the penicillin group of drugs. Next, please. If it's an older child, you could definitely look at povidone iodine mouth gargles, available as 2% solutions, very freely available. And they may also help to bring down the load of bacteria in the involved areas. Next, please. The delayed indirect complications of bacterial tonsillitis in the long run are a little understated. Rheumatic fever and post-streptococcal glomerulonephritis. You have to keep both of these in mind, and that is the reason why bacterial tonsillitis requires to be treated. Whenever you see the exudates, do not hold back your usage of antibiotics. These children do require, otherwise the risk of rheumatic fever and ESGN is fairly high. Next, please. Now, when would you want to hospitalize somebody with tonsillitis? Almost never. But supposing you have a peritonsillar abscess. Now, this is a sick-looking child. Next slide, next button, please. It is a sick-looking child who comes with the uvula shifted to one side and has got difficulty breathing with a significant amount of drooling. Next, please. You see the tonsils and that side tonsillar pillars are very grossly enlarged and inflamed, and they become pale because of the edema. And next, please. You also look at the uvula, it is grossly edematous and shifted onto one side. Now, this child still looks like he's managing his airway, but there are some who may come absolutely with drooling, with extended neck posture, struggling to breathe in air. A close differential in such cases would be something like epiglottitis, wherein you're not supposed to use a spatula to visualize the throat, and therefore at the most starting hint for difficulty breathing with drooling, this child needs to be in a tertiary care center. Anyways, would require IV hospitalization, a ENT reference, and then the decision, if at all, to operate or no, will be taken by the surgical colleagues. Next, please. ENT consultation is also required for evaluating the need for adenotonsillectomy, very similar to what Madam Zeenat has covered. If you are having recurrent episodes of tonsillitis, so you look at more than 3 episodes in 3 years, 5 episodes in 2 years, or 7 episodes in one single year, then the child may benefit with adenotonsillectomy. If there is a background of sleep apnea because of enlarged adenoids and tonsils, then again surgery may be required. And hearing impairment or recurrent bouts of otitis media, chronic suppurative otitis media, they will require surgical consult. Next, please. So the take-home messages are: one, in the clinic, just make sure whether it is bacterial or viral. If you think it is bacterial, there are exudates, there are tender lymph nodes, please do not delay antibiotics for short-term as well as long-term complications to be avoided. To rule out current complications, the most important of them being peritonsillar abscess, and make sure for recurrent ones with systemic signs, you do rule out closed differentials and do not delay surgical reference if needed. Right? Thank you so much. Thank you.
All right. Thank you, Dr. Vishal, for that great talk. I'm Dr. Ravi. I'm sorry I've joined in late. I'm one of the moderators. So there are a couple of questions, if we can get into that. So the first question is by Dr. Subhas Gajaria. He has asked, like, can the early removal of tonsils reduce the immunity in children in later life? Dr. Zeenat, if you can respond to that.
Very early life, up to the age of 2 or 3, if there is a gross, if you're considering a surgical option, that would normally be because of gross adenoid hypertrophy. Now, with the newer surgical procedures and options available to us, we could do a partial removal of the adenoids, clear the choanec, give the patient the ability to breathe comfortably. So when there's partial removal, you would say, okay, the adenoid function is still viable, the patient is not at any risk. But even if the adenoids, which have immune function, yes, I will not deny that. But there have been a lot of studies done. There is nothing on record which shows that a child gets immunocompromised by the removal of the tonsils and adenoids, if necessary. If treatment has been, alternative treatment has been tried, the child is not improving, yes, I would advise removal, there are other immune organs in the body that will take care of the infection.
All right, great. So we have another question, and this from Dr. Sonu Dani herself. So she has asked, like, tonsillar calcinosis. It's usually mistaken for chronic tonsillitis quite often. And what is your recommendation in treatment? Would you recommend tonsillectomy, or how would you treat it?
We find that patients who come with tonsillar calcinosis are usually complaining of an irritant sensation in the throat. There is a repeated complaints of sore throat. There is often accompanied with halitosis. And if all of this is unresponsive to medication, gargling, repeated cultures, it is a form of chronic tonsillitis. And if chronic tonsillitis unresponsive to medication, yes, I would advise tonsillitis. Again, depending upon the number of episodes, how distressed the patient is with the problem. Because if you wait long enough and it's a single tonsillar lith in the tonsil, gargling and supportive measures, that stone, the tonsillar lith, will fall out on its own as well. The issue is more intense if there are multiple stones covering. Yes, suggest tonsil.
And the other question that is coming is, do these liths start occurring in the pharynx?
I'm sorry, I didn't get your question.
Yeah, so do these calcinotic liths which occur, do they start occurring in the pharynx as well?
There's some literature that if you remove the tonsils, then these liths, they start depositing in the pharynx and much lower down, and then they become impossible to remove. So it might be a problem if you actually do a tonsillectomy. Is that correct, or am I wrong?
No, I haven't come across such an instance, Dr. Udani. I'm sorry, I can't really, because I haven't seen. You do get an occasional small little tonsillar lith on the posterior pharyngeal wall, posterior to the tonsil, which can be removed at the time of the tonsillectomy, or could even be removed on mild manipulation in the clinic. But extensive tonsillar liths in the pharynx or something which is a recurrent problem, I haven't seen. This is. It is a form of a chronic infection. The debris collected and exudative material in the follicles of the tonsil.
All right. Thank you, Dr. Zeenat. So we don't have any more questions as such that are there. So I just basically like to thank everyone for attending this masterclass, and also thank all the speakers for really great talks and showing really great cases. I'd also like to thank SRCC Children's Hospital managed by Narayana, as well as Dr. Rasik Shah and Dr. Sonu Dani for organizing these masterclass every week and every month for everyone to see. And even though I'm an orthopedic surgeon, I learn a lot about a lot of other things when I attend these things. And also, please visit SRCC Children's Hospital. As you see, we have a really great team in every department, and everyone is there to manage whatever problem is there with any child at any point of time. And all of us are quite reachable if you have any questions or any doubts at any point of time. I'd also like to let everyone know about the masterclass for next week. And I'm proud to say it's my department. It's the Department of Pediatric Orthopedics. And we'll be talking and focusing a little on why does my child limp? And we have quite a lot of speakers, Dr. Taral, myself, Dr. Mandar, and some of my other colleagues who will be talking a little bit about why does a child limp, and go through some cases which are quite common, which can come to your clinic to help you diagnose and manage them, and if not, know when to refer them. Thank you so much, everyone, for attending this webinar and masterclass, and we hope to see everyone again next week as well.
Thank you.
Thank you.
Thank you, everyone.
Yeah, I think, Rasik, we need to tighten this up. Huh? Too
Yeah.
many glitches should not be.
Yeah, we can stop sharing on YouTube, Arnab.
Oh, yeah. Oh, we are still live?
Yeah.